Hello everyone, welcome to another video of a paraclinoid aneurysm clipping. So this was a young male who presented with severe headache and altered sensorium. On angiography we saw that it was a left-sided ICA aneurysm arising just after the ophthalmic artery outshoot. The patient had left-sided vision deficits, so we started with a standard pterional craniotomy and drilling of the sphenoid ridge. We can see the periorbita and the meningo orbital band which is cut, and we are trying to do a anterior clinoidectomy. Since the patient had already bled, this was a very edematous sort of parenchyma with diffuse subarachnoid hemorrhage. So we had to cut the dura vertically just to release some CSF so that we can continue with our clinoidectomy safely. So after releasing some CSF, the brain was a bit less tense, and then we could see the whole of the clinoid process and the dura over it. A sharp sickle knife to cut the dura, and that's the dural fold over the optic canal, which we are carefully dissecting and cutting. The key here is to stay medial to the clinoid process and not go laterally during the drilling and the biting. So first the optic nerve should be bared, and then we can go for the lateral margin and complete excision. So in this case the clinoid is completely pneumatized, as you can see, and that makes our job a bit easy because we can see both the tables of the bone. And now the dura is being dissected off from the medial and inferior border of the clinoid. So that's the clinoid tip now into our vision. Seldom do we require a brain retractor once the CSF has been drained. Just the initial few steps require a brain retractor. Once the CSF is drained, we adequately have space and we can work in this zone. So as the clinoid is pneumatized, we are able to bite it off, and so now we can see the opticocarotid cistern, and carefully the dural ring will now be in view. So remember, this is the distal dural ring now. After the clinoid is completely removed, can we see the proximal dural ring? The aneurysm here, the dome of the aneurysm is below the optic nerve, displacing the optic nerve superiorly. That has led to the vision reduction in the left eye of this patient. So we have to be very careful along the medial border of the ICA. Careful analysis of the pre-operative angiogram is of utmost importance. So now the whole of the clinoid process has been mobilized, and we are dissecting it off from the dural rings. The flat dissector is very helpful in this procedure, and a tapering needle holder can be used to excise the last bit. So now this is the proximal and the distal dural rings in view, which we are cutting so that the aneurysm and the ICA is completely visible. Here we have taken a neck control, and now this is the final bit of dural ring that has been cut with very high magnification, and the aneurysm is pointing towards the 1 to 3 o'clock in our view. It is yet to be seen properly, the neck, since the dural ring is not yet cut completely. So this ICA that we are currently seeing is the extradural ICA, the horizontal part of the siphon. So now we can see the optic nerve and the dome that is going below the optic nerve. This part is very crucial during the surgery, needs to be done very slowly because the aneurysm is at the risk of rupturing here. So once the dural ring is completely freed from the dural margins, we can start mobilizing the ICA and the neck can be easily seen. This is the lateral border of the ICA, which is safe because the aneurysm is medially directed, and that's where we will initiate our dissection to mobilize the ICA. So that's the dural ring remnant, just a sleeve over the ICA. To the left of that is the extradural ICA, to the right of that is the intradural ICA, and to the right of this particular plane is the optic nerve. So we're opening the opticocarotid cistern deeply so as to identify the distal margin of the neck. We have taken cervical carotid control before the surgery began, rather before the craniotomy began, and we will be applying clamps to the internal carotid during further dissection in just a while. So that's the lateral margin of the ICA. That's where the siphon has turned intradurally, and now we are trying to reach the proximal neck. So that's the distal neck. So we'll have to apply the clip at that particular point, just separating the arachnoid to allow for good clip placement. And here we've held the carotid with the bulldog clamp, applying it on the internal carotid. And then we can safely go into the proximal neck. Now here is where the aneurysm has ruptured, but because we have neck control, we are easily able to dissect around the neck. So that's the fundus below the optic nerve, and we'll go in for straight clip application. I've seen the ophthalmic artery. Unfortunately, we've not been able to record it in the video. So after confirming that both our clip branches are going across the neck, and the fundus is completely occluded. We check for the distal tip of the clip, and the turgosity of the fundus has disappeared. We've released the neck clamp, and this is the final hemostasis. A small pack of muscle at the proximal neck, just to be doubly sure. The patient did very well and his vision has improved completely. Thanks for watching.